This is A&P Live Studio. I am your host. I teach A&P as a registered nurse and anatomy and physiology instructor for advanced level of healthcare pros. I invite you to settle in, take a nice deep breath, and prepare for a really fascinating journey into human physiology. Today, we're exploring a highly complex, multi-system condition, preeclampsia. We'll be tracing its path all the way from the microscopic, cellular level right out to its systemic clinical presentation. Here is our roadmap for today's session. We're going to cover the clinical case and normal physiology, core pathophysiology and genetics, systemic signs and symptoms, disease progression, diagnosis and treatment mechanisms, and finally, a nice clinical summary to bring it all together. Section 1. Clinical case and normal physiology. To truly understand a disease process, we really need to anchor the pathophysiology in a realistic clinical context. Imagine you're an ER or ICU nurse and you meet our patient, J-Lou. She's a 31-year-old female of Hispanic descent. She presents to triage at 26 weeks gestation. Now, during her routine check, you note a new onset of high blood pressure. She also shares a history of a previous miscarriage. This is a very real and actually quite common presentation. While preeclampsia can happen to absolutely anyone, her history of miscarriage gives us a subtle hint about immunologic priming. And that early 26-week onset, that tells us we're likely dealing with a potentially severe placental disorder. Before we dive into what's going wrong with J-Lou, let's briefly review normal physiology. In a healthy pregnancy, specialized fetal cells called trophoblast invade the maternal uterine wall. They essentially remodel the maternal spiral arteries by stripping away their muscular layer. This turns them into wide, high-capacity, low-resistance vessels, which ensures a massive blood supply to the growing fetus. But in preeclampsia, this vital remodeling completely fails. The vessels remain narrow, they're rigid, and they're highly resistant. So this creates a really tough, low-flow, high-pressure environment in the uteroplacental unit. Section 2, core pathophysiology and genetics. Let's transition smoothly from that structural failure right into the molecular and cellular disruptions. At the core molecular level, because J-Lou's spiral arteries didn't remodel properly, her placenta is ischemic. Simply put, it's starved for oxygen. An ischemic placenta gets highly stressed and starts releasing anti-angiogenic factors, most notably one called SFLT1. Think of SFLT1 as a rogue molecular sponge. It floats out into the maternal bloodstream and aggressively binds up vital, healthy growth factors like PLGF and VEG. This essentially robs the mother's blood vessels of the very factors they need to stay healthy, relaxed, and functioning properly. Let's walk through this cascade step by step. Step 1. That initial structural failure causes placental hypoxia. Step 2. The stressed placenta releases SFLT1 and inflammatory cytokines right into the mother's blood. Step 3. This angiogenic imbalance directly causes widespread maternal systemic endothelial damage. The endothelium, which is the delicate inner lining of the mother's blood vessels, becomes leaky, it becomes hyperreactive, and intensely inflamed. So, what started as a localized placental issue has now blossomed into a full-blown systemic vascular crisis. But you might be wondering, why did the trophoblast invasion fail in the first place? Well, the evidence points heavily to genetics and immunology. There's often an immunologic intolerance between the mother and the paternal antigens present in the fetus. At the cellular level, we actually see an aggressive immune response, increased natural killer cell activity, and decreased regulatory T cells, which normally act to keep peace in the immune system. Plus, specific genetic variations, like VGFA single nucleotide polymorphisms, make certain patients structurally much more vulnerable to these vascular failures right from the start. Section 3. Systemic signs and symptoms. Let's move now from the microscopic cellular level up to the macroscopic, visible clinical signs we see at the bedside. I want to pause for just a moment and ask you this bridging question. How exactly does a localized problem in the placenta translate into full-body dysfunction? Remember our 11 organ systems. To help you recall, occasionally remind yourself of the MRS includer mnemonic: muscular, respiratory, skeletal, integumentary, nervous, cardiovascular, lymphatic, urinary, digestive, endocrine, and reproductive systems. Because preeclampsia damages the endothelium of the blood vessels, and blood vessels feed every single organ, multiple systems are going to be directly impacted. Let's mechanistically map this out. In the nervous system, J-Lou might report a severe, persistent headache. Now, this isn't just tension. It's actually from cerebral edema and reversible ischemic encephalopathy due to those leaky vessels in the brain. Over in the digestive system, right upper quadrant pain occurs because leaky capillaries in the liver cause edema, which literally stretches the liver capsule. In the urinary system, reduced urine output and proteinuria happen because the filtering units of the kidneys suffer from glomerular endotheliosis. Basically, the endothelial cells swell up and block filtration. And in the cardiovascular system, intense global vasospasm causes that hallmark hypertension. It's a clear line from structure to function to dysfunction. Section 4, Disease Progression and Complications. Shifting our focus just a bit, let's look at the clinical trajectory if this pathophysiology goes unchecked. This disease really follows a chronological progression. It begins completely silently with asymptomatic endothelial injury. Many patients feel perfectly fine at this stage, but then clinical signs like hypertension and proteinuria start to emerge. If it remains unchecked, the systemic damage progresses to severe features, like HELLP syndrome, which stands for hemolysis, elevated liver enzymes, and low platelets. Ultimately, the cerebral edema can trigger eclampsia, which manifests as devastating, life-threatening seizures. It's absolutely critical to remember that the fetus is experiencing this crisis concurrently. The high-resistance placental vascular bed drastically diminishes perfusion, leading to fetal growth restriction. The fetus simply isn't getting enough nutrients or oxygen. Furthermore, pushing blood against that high-resistance placenta actually increases the fetal cardiac afterload, which alters fetal cardiac remodeling and causes ventricular hypertrophy while still in utero. Very often, the only way to save both the mother and the baby is a premature, medically indicated delivery. Section 5, Diagnosis and Treatment Mechanisms. Let us transition calmly now to how advanced healthcare providers identify and manage this cascade. Diagnosis is really all about connecting our lab findings back to that molecular damage. A blood pressure over 140/90 reflects that systemic vasoconstriction. A protein to creatinine ratio of 30 milligrams per millimole or higher confirms the glomerular filtration barrier injury we just discussed. Elevated AST and ALT enzymes show us hepatic cellular necrosis. And increasingly, modern medicine is looking directly at the angiogenic markers. We're finding reduced PLGF and high SFLT1, basically proving the placenta is stressed and releasing that molecular sponge into the bloodstream. When we're treating patients like JLo, we look at mechanistic pharmacology. As advanced pros, we don't just memorize drugs, we understand exactly how they work. Low-dose aspirin is frontline for prevention. It inhibits platelet aggregation and promotes vasodilation by shifting the balance in the thromboxane and prostacyclin pathways. Interestingly, pravastatin, which is typically a cholesterol medication, is showing promise because it actually raises those healthy PLGF levels and lowers the dangerous SFLT1, enhancing endothelial function. Finally, low molecular weight heparin is utilized to improve placental blood flow and mitigate the microcoagulation that's occurring in those damaged vessels. Section 6, Summary and Clinical Integration. Take a breath and let's tie all of this beautiful, complex physiology together. The journey of preeclampsia follows a very direct flow. It starts with the failure of normal spiral artery remodeling. This leads to the pathophysiology of placental ischemia and the release of SFLT1. That molecular disruption directly causes the clinical presentation of systemic endothelial damage across multiple organ systems, which perfectly explains the hypertension, the headaches, and the organ injury. Finally, understanding this allows us to apply sound treatment logic, using medications like aspirin to target the precise molecular pathways of vasodilation and endothelial protection. And that brings us to the end of our journey today. Please remember, this session is for educational purposes only and is not intended as medical advice, diagnosis, or a substitute for professional healthcare decisions. Always follow your institutional clinical protocols. As we leave JLo's case behind, ask yourself, what other silent molecular imbalances might be hiding behind routine vital signs in your patients? Thank you for joining me in A&P Live Studio. Stay pathocurious and see you next episode.